Hello class, I am Dr. Rustino, and I am going to go over the syllabus with you, go over some of the assignments with you, and kind of put some clarity on what is expected. Let me see if I can move this over. Here I am. I'm going to move this over. So I want to go through the syllabus and then I'm going to go through the class. So my last name changed to Rustino. That's one thing that you should probably know. The course description, the course objectives, you can read. Course format is completely online. What I'm interested in is our assignments. So we'll be covering, we should have already covered 1 and 2, 3 and 4, and this week would be 5 and 6. Discussion 1 is introductions about yourself. And I think I put on there pretty clearly, like, you know, how long you've been a nurse, why are you going back to school, what's your goal, what area of nursing do you work in, those kind of things. Just an introduction about yourself so that the other students, because we're not in the class, can get to know more about you. For the second week, which is last week, a brief synopsis of your conflict resolution paper. You should be working on that, and that is something that has happened to you in the past. And as nurses, we've all had conflict, especially working in healthcare. I don't care. There's something that if you've been a nurse long enough, you had a conflict. And that's what I want you to reflect back on, that conflict, like the one that sticks out in your mind, and write about it. And write, if you had to do it over again, knowing communication techniques and the way to de-escalate situations, how to resolve situations more smooth. At this point, you're senior, so you should already know this about communication. So reflecting back on that, would you have done anything different? Did you do the right thing at that time and you wouldn't change anything? Or what would you have changed? And that's what I'm interested in. It's growth. How would you have handled the situation differently is what I want to know. And that's going to be due on the 23rd. And then we have another discussion due on the 30th. We'll be talking about gender characteristics as well, which is very interesting, how a male leader and a female leader, there are some different characteristics that we carry. Leadership, and then the article synopsis is due on the 30th as well, and that is the article You Permit What You Promote, which I think is a really interesting article. I like that article. I have some other articles that are posted that are really good articles. It makes you think kind of about different environments that you work in and the money that they spend. So the 30th, chapter 9, and then we have discussion 4, which will be due on June 6th. The second paper will be due on June 6th as well, and this is going to be a safety issue. So let's say that, I'm going to give you an example. You're working in a hospital, you're working in the ER, and you don't have enough thermometers, or you can't get the blood sugar machine calibrated and you only have one. That's a safety issue for your patient. So pick a safety issue that you have came across with personally. Sometimes it can be, like for me, it was just brand new RN working in a trauma ICU. I had a patient who was actively herniating. So I was working with this patient. They had to come. They put a ventric in. They were having a hard time getting the ventric in. I put her on nitride to start with because her blood pressure was like through the roof and she was herniating. Well, I gave the nitride too quick and then I dropped her pressure and then I had to start levofed. So I was in this room with this lady all night for 12 hours. And then, of course, you have to take her to CAT scan. So I had to leave the floor. I had another patient who was an attempted suicide who ran his car into a wall, going as fast as it could go. And he was in traction. He had broken pretty much a lot of the bones in his body. He had a ventricle, he had a swan. He was a diabetic. And this is where the big issue came in. He was on an insulin drip. So you're supposed to have the blood sugars drawn every hour. Well, I was actually still in orientation at this point as well. This is like my third day there. And because I had came from an ICU, they just kind of let me go. Came back at the end of my shift to check on the other patient, thinking that the other nurses would take him over. They didn't. No one had checked a blood sugar on him in 12 hours. That's a safety issue, big safety issue, and that was my license on the line because it wasn't done. He had no care done. He had no urine output done, nothing at all. No one went in the room. And I had this lady who was actively trying to die on me, and he was on dopamine and I'm trying to remember. It was so long ago. It was 30 years ago, but I still remember it. Levofed, dopamine, just, blood pressure vasopressors to keep his pressure up. And he was, sick. So then they wanted me to take him to CAT scan. And in order to do that, I had to remove all the traction, which was a new experience for me because I came from the burn ICU. So this traction thing was new for me. And I wound up, taking him to CAT scan. But looking back, that was a huge safety issue. And it was probably, I'm not sure if it was, I think it was that morning I went to the manager and I said, I will not be back. I quit. If this is how your unit works and you're supposed to be a team here, no way, because I'm going to lose my license. So that was a big safety issue for me that no one else helped me. So whatever kind of safety issue that you have or that you faced, that's what I want to hear about, and what you would do, like what you would present to your manager and to solve it, not just to talk about this sucks. I want you to talk about how do we fix it, like problem solve. So could we try this? Could we try that? And even as a bachelor's prepared RN, it is a great thing to do research. So if there's a safety issue that you're concerned with, finding like a CNS or an NP to help you to do research on it and prove what you're talking about is a problem and what you are proposing to fix it helps is a huge, it helps the profession grow. And that's why we do research. So anyway, that's what the safety paper is about. What was the safety issue and how would you propose to resolve it? All right. The other paper that we have that's going to be due on the 13th of June is Shattering a Leader. Oh, that didn't come out right. Shadow a Leader. So one of the exercises that I want you to do in this class is to shadow a leader. And this could be a manager on your unit. This is someone in a leadership position. The best thing to do is to shadow the CEO or someone higher up. Like if you have a CNO, someone who's higher up that you could follow around. And I usually say 4 hours because you're going to be in meetings. Like I was the director of 2 programs, trauma and cardiothoracic ICU. And I think all my day was pretty much a lot of meetings. Like it was things behind the scenes that my team didn't know what was going on. But being the leader, I had to be the one to take the risk and to stand up and to get things done and to make things happen that were fair for my team. And so, not always looked at like this nicey nicey, because you can't be nicey nicey when you're trying to get things done and get them done the right way and make sure that you're compensated for your work. So, being a leader, we'll get into this more, you have to be a risk taker. And taking the risk on standing up for your team and not just, taking what they tell you is the best thing can cause some conflict, and you have to know how to resolve that conflict. But what I want you to do is to follow a leader around for like 4 hours, and then write it up. Like, what did you do? What did you do? What did you see? How did it change your perspective on being an RN at the bedside versus someone who is in a leadership position? Because what you do in leadership and what you do at the bedside are two way different things. And luckily for me, my job was probably 60% leadership, where I was doing the scheduling, I was doing the meetings and the moving our program forward stuff. But then the other 40%, I was at the bedside, and I was always on call. Like, if they needed something, I was there to help. If I had an ECMO patient or a new heart new lung transplant, or someone who had a BIVAD or something like that was really sick, then I would come in and help. But what I did behind the scenes, they never knew. One thing that I did for my staff is I had about 20 NPs after me. I was the first one that they hired, but I had about 20 NPs after me when I left. And every month I would pick one, and I would do an NP of the month. And then so I would take their picture, do like a bio of them, and just acknowledge them so that other nurses knew who they were, the doctors knew who they were, and they were recognized. And every day that I worked, I brought them a snack or socks or whatever it was, candles, just to show my appreciation for their hard work. So it was hard work. The nurses got really ticked off with this on the unit, and they were like, "Why aren't you doing that for us?" So that caused conflict, but that was my choice, and I had to deal with that with the manager, which I did. So I want you to see what it's like being a leader, not at the bedside, and then reflect on that. Write about your experience. Was it good, bad? Was it helpful? Especially if you're getting your bachelor's degree, this is the point that you will have opportunities to be leaders. And when I say to be leaders, I mean management. Because I think a leader can have a diploma, be a diploma nurse, and that is someone that people will go to, that is a mentor, that is a leader on the unit, that is someone who is there for change. And you don't have to have a bachelor's, a master's, a DMP. And you can have all of those things and still not be a good leader. So I'm going to be very careful to say it will give you the opportunity to be into management. And education. Education is another thing that they usually want bachelor's prepared nurses to be the unit educators. So this is a position of leadership. You're teaching others. Sometimes leaders, when they first get into the position, they will have this big ego, like, oh, I'm the manager now, and so I'm going to run a tight ship, and I'm going to do this, and I'm changing that, and it makes it really hard for the nurses. They want to set examples. They want to change things that shouldn't be changed, that are not helpful for the nurses, but maybe they look better, but you look worse. And with good leaders, you'll know that they're servant leaders. And that's what I always try to practice, is being a servant leader. and that is someone who serves my team. So I am just a conduit to them. So making the decisions for them, with them, collaborating with them, and then going in with my guns loaded and saying, this is what we want, this is what has to happen, and not backing down. But if you have a leader who's like a transactional leader or manager, who's about the money, about the task, about making sure your documentation is done on time, about, making sure that the job gets done in the most, I'm going to say, cheapest way, because I'm not going to say efficient. I think they're two very different things. It's very hard to work for someone like that. It's very hard to work for someone who, as a mother, doesn't have children. And when your kids are sick, they don't get that. That's hard. They believe that working for their job is their life. And so I've worked for those type of people as well. I've worked for, different people. And then being the boss myself, I have to be the one to make the decisions on who to give time off, when to give time off. And I'll tell you that no matter what, if someone came to me on my team that wanted time off, I did whatever I could do, even if I had to work their shift, to give them the time off, because that's telling me they need time off. So that, to me, is something that I never wanted them to worry about. Having, to be scared they weren't going to get the time off. And that's just an example of being a leader, making choices. But I want you to reflect back on that. And that paper will be due on the 20th of June. The grading scale is the same as it was for all of your classes in the undergrad. The article critique is 50 points. Conflict resolution paper will be 100. The leadership safety paper, this is where you're going to find the problem and figure out how you would resolve it. The shadowing a leader is 100 points. That's where you're going to follow the leader for about 4 hours. And then the last paper is going to be a reflection paper. And that's going to be reflecting back on the course. What did you learn? How did it help you, and how will it help you to move forward in nursing? And that's what I want to know. Your threaded discussions, I expect that when I write questions, you only have to answer one of them. But I want thorough questions. I want at least one reference, and I want you guys to reply to each other. Because one person may think one way, and another student, 99% of the time, will have a different angle on it, and that's good. We want to stimulate conversation. Don't put someone down and be like, oh no, that's never going to work. That's really not a good idea. That's not what I'm looking for. I want you to support each other in this class. It's not about who's smarter, who knows better. Oh, I tried that, it didn't work. It may not have worked for you, but it might work for someone else. So the cutting down is not going to be tolerated. And I will be monitoring those. This is just the assignments of what I'm looking for. Obviously, this is Canvas that we're going to be using. My availability, I will tell you, the easiest way to get a hold of me is through email. So a lot of times I get bombarded with phone calls. And if it's a number I don't recognize, there's probably 80% chance I'm not going to answer it. I'll let it go to voicemail and then I'll answer it. I'm always getting crazy phone calls. So if you email me, that would be easier and faster. It'll go right to my phone. I'll get it right away and I'll get back to you. If it's something urgent, email me and say, hey, I have a question. I need to call you. And then I'll wait for your call. If it is an IT issue, call the IT help desk, okay? Like if you can't get into Canvas, if you're having trouble with something with Canvas, like if I post this video and you can't see it, then there's a problem. All assignments will be due at 11:59 on the date that they're due. So 11:59 p.m., the date that they are due, that's when they're due. I do expect a small abstract, which is 150 word maximum. So this means that every word that you say to introduce your paper about what it is, like the safety paper. You know, this paper is going to talk about a safety issue that happened to me and how I propose to resolve it. That's it. Like, I don't need a bunch of flubber blubber. That stuff doesn't work. Filler words do not work. Like, for me, every word is impregnated with meaning, and that's probably from being published. When you're published, you can't have the filler, the flutter, all that fluff. No. It's what you say, what you mean, be direct, be clear, and the flow of the paper. It should be just like when you took English. You know, you have your introduction, you want that hook, like, okay, I want to see what's going on. What happened? You want to hook them in. And then the body of your paper and the conclusion. So it should flow into it. And I really like transitions in sentences. So if you can try to be cognizant that when you're on your last sentence, that it flows into the next paragraph, that's good. That's what I like. Because it flows. It makes the flow. Okay, I know it's coming. The University Writing Center is also available. So if you're writing papers and you're having trouble or you want someone to look at it, that would be the numbers on here to call. And they have their hours and they change them for the summer, but they're there. So go ahead and give them a call if you need to. That's fine. Any missed assignments are to be completed by June 6th. So the only assignments that you will have that I will accept are the papers and the discussion that are due after June 6th. I think there's 2. But everything before that, I won't accept. So you should know that. This is just about religious holidays and things like that. And if you do have a religious holiday or you have something that comes up, just let me know, because if I have an assignment that's due and I go and I'm grading and there's nothing there and I don't hear anything from you, I'm going to assume that you're not doing it. Okay? And I am going to post all of the discussions so that you can do it at your leisure. And this is really, the discussions are from personal experience. And I do want one form of like an article or something to back up what you're saying, but I'm only asking for one reference. It could be from the book as well. And at this point, I want an abstract for your papers. And like I said, 150 words or less, and I do count the words. So if you give me 300 words, you're probably going to get marked down, because I want you to think about every word that you're writing. No flubber, no fluff. All right? And then these are just the rubrics for your assignments. Now, this page right here is the page that you would give to the person that the leader that you're going to shadow. You're going to just give them this paper, and then you can upload this to me. And, have them write something on there. Like, yeah, she was here or he was here, and, they followed me around for 4 hours. We went to a meeting. We did this, whatever. We talked about this. They might not have any meetings that day, and it may just be where you can pick their brain. Like, why did you choose to do this? Like, what is the most, what's the hardest part about your job? Like, that's your time to see what a true leader does, what is going on behind the scenes. And then you have the opportunity to say your concerns. So it's kind of like a win-win. Like, hey, on my unit, I noticed that this, and this, and they'll do something about it. Like, I went to them when I was doing a research study. I went to the CNO, and I was doing a research study on music therapy, and this was probably 25 years ago. So this was new. This was something that was not done today. I mean, today it's done now, but this was something that I had this epiphany, and it was in the ICU, that if you use music therapy, and I wanted a music library, because if you use music therapy, it has to be on the music that the patient likes. So someone who is into classical music and they hate country music, if I put the headphones on them and I let them listen to the headphones for half an hour, their blood pressure is going to go up, their heart rate's going to go up, they're not going to relax, they're not going to calm down, it's not going to be helpful for them. So they have to pick out the music, and if they're intubated and they can't speak, their family will know what they listen to, so that's not a problem. But having a music library, having the headphones, and then doing the research, like, okay, this is what my baseline was. Here I started my intervention, which is the music therapy, and then at the end of the 30 minutes, this is what the vital signs were. If the patient is not intubated, they can tell you how they feel, which is even better. But my patients were mostly intubated, and I could tell from their blood pressure and their vital signs the difference. So that was my research a long, long time ago. But I went to the CNO, and I told her about my study, and she actually went to Delta Airlines, and they donated 100 sets of headphones for me. And she brought them in, and she was like, here you go. And then she brought in a bunch of CDs for me, which was really kind of cool. But they were very supportive, very helpful. And they were like, wow, a nurse wants to do something for the patient care, because the residents will do this shit all the time. The residents will do the research, but nurses can do it too. And we need to do it to make our profession grow. We need to prove that what we're doing is worthy and prove it's like, I think more and more, it depends what area you work in, but at least in the ICU, the nurses, how can I put this? They're valued, but they're not respected a lot. Until you get to that point where you're a veteran and the doctors know that they can count on you. When you're starting out, I've seen nurses cry. I have seen nurses in codes sit in the corner and cry. I have seen nurses come on one day and never come back in the ICU. And this was a tough ICU. This was cardiothoracic. And we had some tough surgeons. The veteran nurses were hardcore, and those were the preceptors. I had a preceptor who was there for a long time. And he came to me and he said, he's working with this new nurse. And he's like, yeah, she's just not getting it. I mean, she's not going to make it. She's not going to get it. She just doesn't get it. And I said, then you're teaching her the wrong way. You're not teaching her what she needs to know. That's your fault. And I told all of my nurse practitioners, if you look bad, I look bad. So I don't want to look bad. So I'm going to teach you what I knew. And I trained every one of them. How to do swans, how to do chest tubes, how to crack chest, how to do thoracentesis, paracentesis. I mean, we did all the procedures. We managed all the patients, hemodynamics. Like, that's what we did. And they were on orientation anywhere from 6 months to a year. And I was still on call if they needed me. And they would call me at 2 a.m, like, okay, my PA pressure is this, my CVP is this, my heart rate is this, what do I do? And that was okay. But you have to get to that point that you get that respect. And as a new nurse, you won't. And you're going to have days that you're going to want to throw up going into work. Like, oh my gosh, what am I going to get now? It was like me. I came to work and I swear I had a week of nothing but I cracked 2 chests a day. And I'm not kidding you. And finally on the 6th one, I looked at the wall and I'm like, am I on Canon camera? What is going on? They called me the chest cracking queen. Not that I wanted to, but my patients were dying in front of me and I had to open them up. Only one time, I had one patient with an aortic aneurysm that we knew. He was 35, young guy. Bed rest. The nurse got him up in a chair. He blew his aorta. And they were like, okay, do you want me to get the chest cracking cart? And I'm like, no, call the priest. I'm not opening that. That was it. He blew his aorta. There's nothing you can do. But if there was something I could do, I would get in there and try and help them. And most of the time I did. But something like that, no, call the priest. That's done. But it's getting the respect that we deserve as nurses, and people just don't realize how much knowledge you have to have. And the confidence is the other thing that is very, very helpful as a nurse. You have to be confident. And that comes with experience. That comes, oh, I've done this before. Or if you don't know it, look it up so that the next time you have it, you'll know and you'll be comfortable. Like for me, every time I pushed a drug, I thought, okay, now when my patient crashes, how do I fix it? I was always thinking one step ahead. When I do this and that happens, which is the worst case scenario, how do I fix it? It's like when you go into a code, you are thinking about the problem. How do you fix it, right? You're trying to find the problem. So that's like forward thinking, like trying to stay a step ahead, which is what you kind of have to do in any unit that you're in. Anticipation. So what do I want to do? I want to go to, if I announce anything, I might go away for a minute. If I announce something, it will be under here. I don't do the modules. Assignments, I will add the assignments, and they should be able to be uploaded. Discussions will be where the threaded discussions are. There's no quizzes in this class. We don't worry about that. Panopto recordings will come to you. Grades, that is where your grades will be. I gotta get out of here. And the rest of, there's files. Under files, let me know if you guys can get this or not. But that is where I have the other articles. So if you can't get to them, like estimating the cost of a professional growth, that's a good one. Balancing the cost of healthcare, that's good. It depends. They're all really good articles. And they're, not super long. And by the way, your paper should not be more than, at the maximum, 10 points. 10 points, I just said. 10 pages at the most. It should probably be around 5 pages. These are like personal pages. They're not research pages. You've already had research. That's not what I'm looking for. I'm looking for personal growth and how you would problem solve issues. I'm trying to download this thing here. Let me see. Okay. So this is just something that was one of the statements that I had to make. And when I took a leadership, I am a leadership fellow and been through leadership courses. This was a formal one that actually lasted a year, and we had to do a huge project at the end. But I believe a leader should be genuine, loyal, and dedicated to making their team as strong as possible. Leaders should take risk in order to move their team forward and be ready to stand up for issues that directly affect their team. That's big time. You can't be afraid to stand up for your team. They need to have follow through and keep promises. So if you say something, do it. A leader should not ask their team to do the tasks that they would not do themselves. So again, your leader, manager, leader, whoever it is, should not be asking you to do something they wouldn't do. The leader should be there for guidance and support for their team and encourage personal and professional growth. So they should be encouraging you to do research, encouraging you to go to conferences, encouraging you to get certifications to better yourself. As a leader, I have a transformational style, and I would hyphen that at this point and say servant style. And this is before I took the thing. This is in the beginning of the course. I believe in asking for input from the team, so I'm not a dictator before I make the final decision, unless there are circumstances that would require me to make a quick decision for the team, then I would. And I am always approachable and available for my team to support their decisions. And if they have suggestions, I definitely would take it to who I needed to. I am a risk taker, not afraid to stand up for any issue that directly affects my team. I'm loyal and committed in encouraging personal and professional growth for my team. So I would encourage, if I saw a conference and I knew one of my NPs was weak, especially in one of the areas that the conference is about, like pharmacology, I would say, okay, there's a pharmacology, conference coming up. I want you to go. I believe in having a strong team player will it will make the whole team strong if you are team players. And we're going to talk about leaders and followers in this lecture. I expect my employees to be committed and dedicated to our team. That is true. So when somebody called off, I could call probably 5 and they would be ready to come in, and I would do the same. I expect my team to be able to communicate their needs and come to me for any concerns that they have, knowing that I have their best interests at heart. If you don't have that trust in your staff, or you think you're going to go to your leader and it's going to fall on deaf ears, that's not going to give you a lot of confidence. I will be a strong leader for my team with tenacity and the ability to strive to achieve our goal as a team. And I expect that my team will work harder, knowing that their leader supports them and will do whatever it takes to make them progress in a positive manner. That's a good word. Manner. So that was just like one of the exercises that I did as a leader. And this is, again, before I went through the whole course. Now my leader would be different. I would be a servant leader. Definitely transformational, though. I was never a transactional leader at all. But these are where, Patient Safety 2010, SAMR, that's a good article. Transformation for Leadership, they're all really good articles. So if you can't go to the files and see the articles, let me know and I'll download them and post them. Can nursing win the game? That's a really good one. All right, let me see. I'm just going to run through this really quick. So this is the book, and I'm using the 4th edition. There, I know there's newer ones, but I didn't upload that one. So it's the same concepts, so it really isn't detrimental if you have a different version, because most of our stuff is going to come from articles and my lecture, what I say. So I'm not too worried about the edition. Like, you're not doing papers from the book. But I want you to read the book because it does have the concepts in it. So these are just theories. The great man theory, the trait theory, situational theory, and contemporary theories, which there's a ton of theories. You guys probably by this time already have certain theories that you are comfortable with, that you like more than others, and that is, already embedded in you. So task of leadership is envisioning goals, affirming values, being a motivator for your team is huge. Managing not only your staff, but managing the day-to-day work that goes on behind the scenes to make the team the best that you can. Achieving a workable unity. So you want the team, this is where the morale is. So if your morale is really low, and it's like and you guys know this, there are nurses that come to work for a paycheck, okay? They don't want to learn. They don't want to be there. They're not involved. They do the least amount to get through the day, and that is not a workable unity. You want nurses to be motivated and to want to help each other and to do the best that they can for each other and the patients. Explaining why, if there's a change or something is different, why. You have to get the buy-in of the nurses. You have to get buy-in, or they're going to be like not helpful. They're going to resist. Serving as a symbol. So this is like being an example for your team. This is how I act. This is how I treat situations, and this is what I expect from you. Also representing the group. Again, the leader, the manager, is a person who represents the whole unit. And then renewing. This is follow through. Keeping true to your word. Developing and renewing others is personal attention. And that's why I did the every month. I'm a nurse practitioner, so I did every month of a nurse practitioner, the bio, and just acknowledging them. Role modeling for not only my staff, but for the nurses. Precepting, again, I precepted every nurse practitioner that I trained, and I did this as a nurse as well. I was precepting and mentoring constantly, but I like to teach. Chapter 2 is the new world and new leadership, changing our thinking about leadership. It's changing. So a good leader will have a vision, they have courage, and they have humility. Again, when you get into a position and you're a leader, okay, this is a new leader, the humility part is the part that usually is the last to come, because they get a big head and they think, oh gosh, I have the power now, and I'm going to do this, and I'm going to show examples. And I'm going to change this and change that, and we're going to do this and we're going to do that. And this is not a humility concept. This is not somebody who is humble and who is working for the team. It is someone who wants to rise above and show that they have the power, and who cares what happens to their team, and that never works. Nurses need to stop dwelling on tasks and instead focus on facilitating the processes needed to obtain the desired goals. So stop focusing on what's wrong and figure out how to make it right. Okay, so if you have a problem, and this is going to be addressing your safety issue, don't just complain about the problem. Think about how to resolve it and move your unit to growth. Fix things. Instead of complaining about it, fix it. It doesn't do any good to complain. All right, so supporting perspectives for new science of leadership. So cognitive and intellectual development theory, developmental theory, complexity theory, and then perspective transformation. Those are all in your book. Fellowship and empowerment, effective or exemplary followers. Now, people that are effective followers are, I'm the leader. And I come to you and I say, okay, we're changing this. We're changing using, we're not going to use heparinized IV flushes anymore. We're just going to use saline flushes. And I'll tell them, look, the research supports that there's no difference in, keeping the vein patent with heparin versus saline, okay? Now, if you have a fresh surgical patient, this is even more. You don't want to give them heparin, right? Okay, fine. You got to get the buy-in. And those people will be like your happy followers. They're, oh, okay, that makes sense. They do it. Alienated followers are the people that give you resistance. They will blatantly tell you they're not going to do it. They don't want to do it. They're against what you're telling them. And they will be the ones that have a hard time adapting to change. These are the people that don't like change. Then you have your yes people. These people don't want any conflict. They just want to come in, do their job. They don't give a crap about what's going on. They want to get their paycheck and go. These are, yep, okay, I'll do that. Sure, no problem. Yep, sure, yep. That's not real helpful either, because they're not bought in. They're not in it for the team. They're just trying to get through on their own. And then the sheeps are the one that will actually try and do things behind your back. They act like they're going to do things, and they'll do things behind your back to try and prevent growth in the unit. And those are the ones that you really, really have to watch out for. It's like a lion in sheep's wool. The dimensions of fellowship styles, you have the partners, the contributors, the politicians, and the subordinates. The partners are people that are, again, going to want to see growth. The contributors are the people who are working. They're working towards it. The politicians are the ones that are going to give you the rough time. Like, I really don't agree with this, and I really don't think I want to do it. So those are the ones that you're going to have trouble with. And the subordinates are the flat out, I'm not doing it ones. And I remember going from paper charting to electronic charting. And I remember how many nurses actually retired or quit their job and got something else because they did not want to go to electronic. It was too hard for them. They were older. Some of them just flat out would not do it, and they actually quit. They left. So the 5P follower model, participant, you have the pessimist, you have the passenger, you have the pig, and the prisoner. So the 5 Ps, and those are all going to be followers, and they're going to be on every unit. You're going to see them on every unit. Sources of power can be legitimate. They can be coercive, like you try and coerce someone into doing something they really don't want to do, but you try and coerce them. Or rewarding. If you do this, I'll give you that. It's ultimatum. The experts, and then the reference. Also knowledge. Knowledge is power. Knowledge is a big source of power. I'm going to stop at chapter 4. I'm going to talk about conflict because we're doing a paper on conflict very briefly. So conflict, clarifying communication. Be open, be honest, tell the truth, and you don't have to worry about it. Avoid taking sides. Try to reserve your judgment until the issue is clear. So if someone comes to you and says, oh my gosh, she did this and she did that, and she's not doing this, wait until you hear from the other person, because that's a one-sided argument. Avoid highly emotional confrontations. If it's starting to escalate, you want to avoid that. And if you can't de-escalate it, you need to walk away and go get someone who can, like the manager, the leader, who would be able to step in and de-escalate the situation, and that happens. Work towards congruence between the role and the status. So make sure that you're doing what you're supposed to be doing. You're doing what your expectations are. And work towards congruence among power, authority, and competence. And this is, being confident and being, I'm telling you, for me, certification is key here to prove your confidence. It's like validation of confidence. Ways of managing conflict. Engage in reconciliation. So take time to walk away and then come back and try and revisit it after you blew off some steam. Employ problem-solving skills. So look at how you can resolve the issue. You might have to compromise, okay? So you do this part, I'll do that part. Compromise. It's a relationship. In all relationships, there's compromise. Whether it's work, love, family, whatever, there's compromise. It can't always be your way. That's called a narcissist, and we don't want those people. Work towards mutual alliances. So you want to try and work towards being a team player. Go on strike, engage in arbitration if it's something that's really, really bad. And we've seen nurses do this, where they've treated like crap, they're not being compensated, they went on strike, and it happens. It's like, really, that's to the end, standing your ground. Develop the needed skills. So this is through either going to someone on your unit who's a veteran nurse who you're weak in something. Like, let's say you're weak in reading 12 lead EKGs, or you're weak in reading, you're weak in lab results, okay? Like, and I'm not talking lab results. I'm talking about if you get a gram-positive let's say it's streptococcus, okay? You should know right away that you're going to need a gram-positive antibiotic. So something like amoxicillin, Keflex, whatever, okay? If it's like a gram-negative, then you would want to use something like Ansef or something that's going to cover gram-negatives, right? Like Vanco is the big one for MRSA, right? That's gram-positive. But if you're weak in that kind of stuff, it could be anything. Go to someone who can help you on the unit. If they can't, that's when you go and you read and you research and you know it and you read it. Or you go to a conference and you sit through experts talking about the areas that you're weak in, and then you become strong. And sometimes you become the strongest on the unit. One of the things for me was 12 lead EKGs. When I first started out in cardiothoracic ICU, I was a nurse. So I wanted to read 12 lead EKGs, though. That was something that I really wanted to do. And I took class after class, I read book after book, and then I wound up teaching it because I was the expert. So it was just making that choice of, I don't want to not know, I want to know, and taking the steps to know. And then, it worked out great because I teach it now. A big part of it is identifying the source of conflict. You have to identify what the problem is. And that's going to come from the direct issue. Not putting a Band-Aid on it, not overlooking things, but looking at the conflict and hitting it head on and addressing it. And participate in integrative decision making. So you want to be part of what happens in the unit. So to transform followers, you need to challenge the status quo. This is, again, adapting. Inspired a share vision. This is for the whole unit. They share the vision and they buy into it. They want to do it. Enable others to act rather than react. You want them to know what's coming, not hit them from behind and say, hey, we changed this. We went to EHR, sorry, get used to it. No, this is coming. This is what you can expect. And you have a choice. Either you do it or you need to look for another job or look for a different unit, whatever it is. But this is what's coming. This is what our vision is. You want to be a role model. I have had nurses who have been on units, and they say nurses eat their young. It's true. Hopefully you've never experienced, but I have. And I know many, many nurses who have. As a new nurse especially, or a nurse that's not real confident, you want to go in there like a sponge and look for your leader, look for the person that's your preceptor, and hope to goodness you get a good preceptor, because there are some that eat their young. And I've had nurses who have quit nursing altogether because of this. So be a role model, whether you've been a nurse for a day or for, like me, 31 years. Always be a role model. Carry yourself like a role model. And if you don't know the answer to something, that's fine. Nobody knows the answer to everything. Look it up. Look it up with the person who's asking you questions. Look it up. There's resource after resource, okay? And encourage the heart. So work from the heart. You're doing it you're a servant to the public. That's what you are. 8 habits of highly effective people, being proactive, not reactive. Begin with the end goal in mind. What do you want the outcome to be here, and how do you reach that? Think about that. That's what I always did. It's always, what do I want to have happen? Where is my vision for this going? And then it's the steps of getting there. Put first things first. How do you get there? Think this is win-win. And find situations that are win-win. Seek first to understand and then to be understood. So you have to understand it before you can be understood. You in your mind have to be able to explain your reasoning, your rationalization before you can make other people understand what you're saying to them and trying to get buy-in from them. Synergize your thoughts. Put everything together and synergize. Sharpen the saw. This is being proactive about the future, using your vision. And again, I have to say research pops into my head here because that's being very proactive. And it doesn't have to be a long, complicated research study. I mean, this, you can go through the IRB, and unless it's like really harmful to someone, you should have no problem getting your IRB approved, okay? And that's the Institutional Review Board that goes through all of the proposals for research. It's not hard. And then find your voice and encourage others to find theirs. This is standing up for yourself. This is being true to yourself. This is looking at how to make the unit or where you're working a better place to work. No one wants to come to work getting that sick feeling like, oh my gosh, please let this shift go by fast. Like, I don't want to be here. Oh my gosh, what am I in for today? And trust me, I think we've probably all been there and worked in units like that. But that's not where we want to be, okay? Close this. Let me come back. Here I am. Okay. So that's just a little tidbit of some concepts that I want you to be aware of. If you have questions, feel free to email me. But they're very like common sense stuff, right? But sometimes, especially, it's just our makeup. Some nurses are there to learn, to help, to be role models, to be leaders. And the difference between a leader and a manager are two completely different things. You do not have to be a manager to be a leader. You could be a leader on the unit. Again, you could have a diploma and be a leader. Someone who cares about the unit, someone who's knowledgeable, someone who's a role model. That is a leader. Someone who people go to for advice, for help. That is a leader. The manager is going to be more worried about tasks, making their budget. When people call in sick, they have to worry about covering it. So they have a very different role than they're a leader, but they're different. It's almost like most of the nurses that I've worked with, the nurse managers, were transactional managers. The leaders that I've worked with were nurses that were leaders, and they were bedside nurses. So your experience may be different, and it'll be interesting to find out how your experience has been. And when we get to the gender difference, that will be an interesting topic as well, because men tend to have very different characteristics and handle situations very different than women, okay? So that will be an interesting conversation and discussion that we have as well. But I think I got to chapter 5, and I'm going to stop there because I don't want to bombard you. It's been an hour, so that's enough for one video. I'm going to send this out to you and have you read it, and I will get started on the discussions and anything else that I think I might want to add. And I'll make an announcement when that's done. What else do I want to tell you? A little bit about myself. I started out in nursing in 1988, so I've been around for a long time. A lot of different changes I've seen, a lot of changes. There were no like bans for barcodes. We had to mix our own medication. We had glass bottles. We had our cardiac output machine look like a dinosaur. We had to calibrate it every time. We had to use like D5 and ice water. I mean, it's totally, the technology has changed over the last 30 years greatly. Safety has been a big issue for nursing. Medical errors, we know that it's about 100,000 medical errors a year, and that's what they're trying to cut down on. This is a huge money killer for hospitals because they get sued, right? And it's nurses, you know, if it's nurses making medical mistakes, and it's anesthesiologists too, it's whoever handles medicine can make the mistake. But now with the barcode thing, I think it's a little harder to make mistakes, which is great. But we used to mix our own epinephrine drips, dopamine, dobutamine, Primacor, anything that had to be made or mixed, there was a drip, we did it. We mixed our own potassium, magnesium, all that stuff. And I think it's all like now done. I worked in the burn ICU to start my career, Detroit Receiving. Then I went to Oakwood and I was in the ICU, but they did hearts. So it was, and I was drawn to the hearts more than the septic, GI, sick patients, traumas, you know. I like the hearts. And then I went to Henry Ford and I worked in the trauma ICU there. And then I worked in the cardiothoracic ICU at a different hospital. And I was a CVRN, so I worked in the OR harvesting veins and doing open heart surgery, first assisting. And then I became an RN. Oh, I did labor and delivery too for a couple years. And I did that contingent while I was going to school. So I did that for about 3 years. But I was just only in charge and I only took the high-risk patients. So, and I scrubbed and circulated and all that. Usually I scrubbed because I was a first assist, but that was when I was going to school to get my NP, and that was 2001. So I've been an NP for about 17 years, and I started the first nurse practitioner program in a cardiothoracic ICU that did heart transplants, lung transplants, ECMO, like big time aortic aneurysms, like sick patients. And they hired me to fail because I was a nurse practitioner. And they had PAs on the floor before that the nurses were having problems with. So when I came, I was female and I was a nurse practitioner, and that was a double whammy. It was the old boys club, and I was definitely not fitting that. Unfortunately, or fortunately, I was tough and I stood my ground. And I made a lot of changes, good changes. Then they hired another NP who was an ER NP. He was stuck to my pocket. There was just the two of us. Stuck to my pocket for a good year. He didn't know hemodynamics, cardiac outputs, how to like interpret, what an SVR means, the whole hemodynamic. I'm not going to get into all that. But teaching him. And then when I left 10 years later, I had 20. When I left, 19 of them left. One of them stayed eventually to be not there anymore. And she stayed, and they gave her like a $25,000 bonus to stay. It didn't last, but when I left, all of them left. So I went to trauma, and I was a trauma director. And that's what I did for probably about, I'm trying to think, 7 years. And so my background is different because it's burn ICU. I did labor and delivery, a lot of ICU, cardiothoracic, trauma, the fresh traumas that come in, which was in the ER, they would call it trauma, and you would have to, go and do your trauma assessment and take care of the patients. But that's kind of a little bit about me. Trying to think if I want to tell you anything else. I had a house fire April 12th and lost everything, so that's why I'm kind of behind, and I have like no beds yet. I just bought a couch though, so that's good. I have something to sit on. So this was just like really putting me behind. So I'm catching up, and I will catch up. You will be fine. We'll get through this. But for me, I just had like a major trauma, and I lost everything. And I moved in there 2 weeks before this, so everything was brand new. So that's why I'm kind of like, I'm dealing with a lot of different places, trying to figure out how to rebuild. So that's like the delays is me. They threw away my computer. I didn't have a computer. I'm teaching an online course, kind of need a computer. So bear with me. We'll get through this. It will get better. If you're going to be late on an assignment, you have something coming up, let me know. I'm cool about that. I understand life happens. Things happen. Just communicate with me, though. I asked of you to communicate with me when something like that does happen. I want to see you interacting in the discussion. I'm going to be monitoring that really close. And if I see that you're not interacting, I'll probably shoot you an email and say, hey, maybe you could make your answers a little bit more comprehensive, a little more thorough. I don't like that. Don't give me yes, no, I agree. Nope, none of that. I want your thoughts. I want you to cognitively use your brain and think things through. You'll notice that sometimes I get hung up on my words. 2015, I was crushed by a semi, and I had a close head injury. I had 2 strokes after that, so I couldn't speak for 6 months. So sometimes my words will get messed up, but I usually can get them out now much better than I could. But sometimes I get hung up on my words, so just bear with me with that. It's better, but it still happens every now and then. So just know that. And I think that's all I want to say for now. Again, if you need to get a hold of me, just the best way is email. And I will be back on with more lectures for you and more announcements for you. It's just been my fault because I haven't had a computer. So it's hit or miss with the computer. So I bought one. I'm good. We'll get things on track. Didn't anticipate a fire and losing everything, literally everything. I went to open a can. I didn't have a can opener. Little things like that you don't even realize that you need. It's quite the experience. Hopefully none of you have went through this, but everything burned to the ground. So we'll be back on track. Have a computer, so we're good. We're good. All right. With that being said, I will let you go, and I will send this out to you. If you don't get it, let me know, and I'll make sure that you get it. I think that's it for now. And start working on your papers, okay? Most of it is going to be personal and things that have happened to you and your reflection back on it. So it's not big research papers. It's personal things. And it's a way for you to grow. Looking back, what would I have done different? Looking at this problem that we have as a safety problem, how would I fix it? What would I propose? And you'll be surprised how many students I've had that this has happened to. They've done this, and they will actually come back and say, I did this, I went to my manager, and we changed it. And wow, what a difference. So things can change because of you. So don't underestimate yourself. And don't ever, ever say, I'm just a nurse. That drives me nuts. That's one of my pet peeves. Just a nurse? No, you are a nurse. Be proud and loud about that. So I'll leave you with that. And you guys have a good day, and I will be back soon, okay?